So good morning, everybody. It's a pleasure to be here. And first of all, I would like to thank, as being the first speaker, I'd like to thank the organizing committee of AIOC for giving us this opportunity. So I would be talking today about PDR, and it is one of the most challenging surgeries that at least I feel I've learned through the years. So as we all know, PDR is basically a proliferative vascular retinopathy. And what differentiates it from simple PVR is basically the vascular nails, which are basically the vascular connections between the retina and the fibrovascular tissue. Then it is the hemorrhage. So hemorrhage is also another component which plays a very crucial role in understanding PDR pathoanatomy. And the third most important thing is vitreoschisis. I think this is one element of PDR which basically makes a surgery difficult and easy. It is very important to understand vitreoschisis because it is basically it helps us to get into the right plane of dissection, and that is extremely crucial and critical to make a very simple case, keep it simple or make it extremely difficult. So we'll just go through this small animation. So as we all know that the vitreous is composed of the vitreous gel and the vitreous cortex, and as I had mentioned earlier, hemorrhage, which creates a cleavage plane into the vitreous cortex, cleaving it into two leaves, the anterior leaf of the vitreous cortex and the posterior leaf. And it is very important to understand this phenomena because this is what makes dissection simple. So the green arrows point towards the anterior leaf and the blue arrows towards the posterior leaf, and it is very critical that we understand this so that we are able to get between the or under the blue arrows, which is the plane between the retina and the vitreoschisis. When we come across diabetic vitrectomy, I think these are the points which are kind of highlighted or which we need to kind of go one by one and understand. So pre-op anti-VEGF, I think, is one of the most commonly used platform, I think, which is used extensively, and it makes the field quite, bloodless and atraumatic. Combining phacoemulsification with diabetic vitrectomies is a good idea because you can very easily tackle anterior prolifs, and also gives us a good base excision and a good view to tackle these membranes. A normal PDR vitrectomy, you would obviously need to create an area of separation in the posterior leaf of the vitreous cortex, and this is usually found in the mid-periphery or at the posterior pole. So going through this video, this is a very typical can opener technique where you find your cleavage plane, and after creating a cleavage plane, you basically can extend this and go all around, separating the posterior prolif from its anterior extensions. And so this would be a very classical way of entering into the posterior hyaloid, or a can opener technique that we do understand and go through. And till you are able to finally complete the entry into the posterior hyaloid 360 degrees. In this next video, we understood the pathoanatomy through an swept-source OCT, and then we created the cleavage plane again in the temporal periphery. And because there was very tight attachments of the membrane anteriorly, there was a point where we had to stop. And then this scleral depression helps us to again find our cleavage plane. With the cutter suction, we are able to kind of pull the posterior hyaloid a bit and then create a cleavage plane there. And with the help of dissection itself and very carefully separating the anterior extensions of the membrane, we complete the entry into the hyaloid. In this case, this was a morbid condition where it was all stuck. So we take a needle and make a entry into the posterior hyaloid at the posterior pole. So the difference is that in this case, we are going from posterior to anterior, unlike others where we went from anterior to posterior. And then again, we complete our entry into the hyaloid 360 degrees. Now coming to the next component, which is bimanual surgery. I think bimanual surgery helps us a lot using cutter forceps or cutter scissors. So in this case, we studied the anatomy on a swept-source OCT pre-operatively. And you can see these vascular nails of connection and also the anterior and the posterior leaves. So bimanually, we are able to create the cleavage plane and then very carefully go dissecting all the vascular nails or the vascular connections which are there, bisect the membrane into smaller prolifs with the cutter section alone and finding that cleavage plane, and then continue our membrane dissection over the posterior pole trimming the fibrovascular proliferative along the way, and then completing a dissection in the nasal quadrant as well. And if you see that, bimanual surgery gives us a very good control, and you're very comfortably able to manage all the vascular nails and connections without causing any iatrogenic breaks. In this case, it was very important because this was a one-eyed lady, and I was, very petrified to create a break in this case, because I didn't want to use any tamponade, and wanted to, give her a considerably quick recovery. This is again a technique of bimanually, taking the flute needle and a cautery in one hand, and bimanually managing all the bleeders. And then finally, we kind of dissected the superior membrane. And thankfully, there was no tamponade being used in this case ultimately. So what makes it morbid? I think it is the anterior proliferations. It is very tight adherence of the posterior hyaloid, and extremely dense clotted heme, and also a detached retina. So in these cases, because you cannot really study these cases extensively, I think there are no definite rules, but I think just go by your instinct and patience, and also by the methodologies and things that you've learned through your way. So this was a case of a very extremely morbid PDR where there was no view, there was layers and layers of heme. So I think it is important to keep the cutter tip up and kind of go layer by layer, and slowly kind of identify all the structures through your way, and clear up the heme, ultimately again going to bimanual vitrectomy, and managing the membranes. And ultimately this had a detached retina also, so we kind of very carefully dealt with all the membranes and completed the bimanual surgery. Again, in these cases, I think bimanual is the only way to go, which is very controlled, and you would not end up with more iatrogenic breaks and bleeders. And finally, we are able to get rid of the membrane and tackle this case to the best of our abilities, and finally put in tamponade. The other situations could be, again, anterior extensions and coexisting macular holes or combined detachments. So in this case, we had a coexisting macular hole where we first took care of the membrane, which was over the posterior pore, over the macula, and then finally did ILM blue staining. One of the tips in this case is because they're very edematous retinas, and you could very easily create a plane break. So it's important that we go from anterior to posterior, so as to not inadvertently enlarge the hole further. In this, the next video is again associated challenging situation where we had this extensive membrane anteriorly. So contact lens use is very good in these cases. And with the contact lens, you get a very clear field of view, and you're able to manage the membrane atraumatically. After the membrane is managed, then we kind of secured the posterior pole with the PFCL, and this was basically done so that we don't drag the the subhyaloid heme, the subretinal heme further down, and ultimately made a retinotomy. And if you see that first we are trying to manage the heme with a single forceps, but you get a good touch, but then again you leave it. So again, in this case, I think bimanual surgery, bimanual technique helps, and with the hands-on-hand technique, the subretinal heme is kind of tackled. Yeah. So this is a case of, again, a morbid situation where you have a combined detachment. In this case, again, if you see nasally, the cleavage plane is there. The heme with a soft brush helped us to find the cleavage plane. And I've kind of realized that once you find the cleavage plane, initially, I think the membrane dissection becomes extremely easy. And you're able to kind of identify all the the tags or the vascular nails, whatever you call it, and slowly you're able to kind of remove the membrane quite atraumatically. In this case, we had an inferior nasal pre-existing break, so again bimanually we kind of went around the break, trying not to extend it any further, and finally completing the case. And this was again anterior extension of the hyaloid, and kind of separated that. and finally we completed the case with tamponade. So I think to summarize, I think PDR vitrectomy, I think my take would be that understanding vitreous cases and finding the right plane of dissection is very important. I think we should do that first and adhere to the surgical principles, whatever the case may be. I always tell everybody that, vitreous hemorrhage is not easy. It is one of the most challenging situations because you might just end up with a taut hyaloid and, that could make or break the case. And you need to be patient. I think that is very important, and be ready to alter your plan whenever. Thank you.
Thank you. It was an excellent talk with beautiful videos. Any questions? We have a very, very small audience, so we can make it more like a group discussion. If anybody wants to give their input, so what they do differently, or how often all of you doing bimanual surgery in your cases, or putting chandelier. Sir?
Sir, I am doing in a complex PDR cases. What difference I found that usually I do with the normal illumination, but when I use this chandelier, I feel a little bit low illumination while doing a bimanual. So can you help us?
Yeah, Dr. Gagan, I think Dr. Dhanashree had a similar question, so we'll club both the questions together.
See, I think as
Gagan,
well as...
Dr. Ma'am also asked a similar question.
Yeah, this is a very good question actually. Even I was looking at your videos and admiring the illumination because even when you put the chandelier, although you can increase the intensity of the chandelier, but sometimes you don't get a very diffuse good illumination. There is some part which is lighted and some part which is dark. So what is your trick in having
Okay,
a good
the tip and
illumination?
trick, one first tip is that I think I think you should do a very good base excision before you put the chandelier, because I've seen that if the base is not very, then it illuminates that area too much. That is one. Secondly, I use a superior chandelier and sometimes an inferior nasal chandelier, depending upon where your membrane is. Like these cases obviously had all over, so I use a superior chandelier. Ma'am, as far as the illumination is concerned, my honest answer would be investment, because one is the recording systems, and secondly, these videos have been, I think 2 videos at least, the one which look really bright, are on an RTVO system. So that gives us a hybrid illumination at that time. So that really helps. And I think with 3D surgery, I think the only benefit that I've found is PDR vitrectomies, because it gives you a very good field of view and very good depth. And obviously the illumination is superb.
Yeah, I think that's quite important. Any other questions? Okay.
Sometimes one more trick is that sometimes you can use the chandelier in a exchangeable manner. So sometimes I'll put 2 ports for chandelier, one inferiorly and one superiorly, and you can shift from inferior to superior. So once you finish one quadrant, then you shift the chandelier to the other quadrant and finish the other. So you have equal illumination in both the quadrants, except that your number of sclerotomies will increase.
Yeah, that's the advantage of using the 25 gauge. You can put it wherever you like. So I wanted to ask Dr. Dhanashree, what is your preferred location? Because most of the time we're putting it superior, but the Egyptians who are very skilled surgeons, I've seen they're putting it inferior nasal in most of their surgeries. So how do you decide where to put the chandelier?
So it depends on where your maximum dissection is going to be. So if it is going to be superior, then I would like to put the chandelier inferior so that it will illuminate the superior area. But if the dissection is going to be inferior, then you put it superior. But as a routine, I put it at 6 o'clock because it is little convenient and it doesn't hamper your movement of the eye or other instruments. But as I said, depending on the quadrant involved, you can take a